Poverty and Its Impact on Women's Health by Cameron Cardone. When we talk about poverty in relation to women's health, it's important to understand that poverty is more than just not having money. It's actually a social condition that affects access to basic needs such as food, housing, education, safety, and healthcare. Because all of these factors are directly connected to health, poverty plays a major role in health outcomes. When someone lives in poverty, they're more likely to experience illness, have limited access to medical care, and face conditions that make existing health problems worse. Poverty also affects women differently than men. Women experience poverty more often and more intensively for several systemic reasons. On average, women earn lower wages than men. They're also more likely to take on caregiving responsibilities, whether that's caring for a child, elderly parents, or other family members, which can limit their income and career opportunities. In many communities around the world, women also have less access to education and stable employment. This affects their long-term financial independence. Because of these factors, women are more likely to live in poverty, and as a result, they face greater health challenges. Poverty doesn't just affect finances. It has direct physical and mental health consequences for women. First, women living in poverty are at higher risk for chronic illness like heart disease, diabetes, and high blood pressure. These conditions are often diagnosed later because women in low-income situations may not have consistent access to health care. By the time they receive care, the condition may have already been advanced. Second, poverty is strongly connected to poor nutrition. Limited income can lead to food insecurity, meaning women may not have reliable access to healthy, nutritious foods. Instead, they may rely on lower-cost processed options that lack essential nutrients. Over time, this can cause nutritional deficiencies, fatigue, and long-term health problems as it becomes even more serious during pregnancy. Poverty is also linked to higher rates of pregnancy complications. Women with limited financial resources often have reduced access to prenatal care, which increases the risk of maternal health issues and poorer birth outcomes. Finally, poverty has a major impact on mental health. The constant stress of financial instability, caregiving responsibilities, and limited support systems can lead to anxiety, depression, and emotional exhaustion. So overall, poverty affects women's health on both a physical and mental level. When we look at the United States, it's important to start by recognizing that this is one of the wealthiest countries in the world. It has one of the most advanced healthcare systems, leads in medical research and innovation, and spends more money on healthcare than almost any other country. Because of that, many people assume health outcomes would also be among the best globally, but that's not necessarily the case. Despite its economic prosperity, the United States has significant wealth inequality and a persistent gender pay gap. That means access to healthcare is not equal. While some individuals have access to high-quality hospitals and specialized care, others struggle to afford basic services. Healthcare in the United States is heavily tied to employment and insurance coverage, which creates gaps, especially for low-income women. Women are affected by poverty in the United States. This is largely due to wage inequality and unpaid caregiving responsibilities and interruptions in employment related to child care or family care. When women experience economic instability, it directly impacts their health. One of the most concerning indicators of this inequality is maternal mortality. Even though the United States is a developed, high-income nation, it has the highest maternal mortality rate among other comparable countries. In 2023, the rate was 18.6 deaths per 100,000 live births, compared to an average of just 5.1 in other high-income countries. This makes the United States an outlier. This statistic highlights a major paradox. The country spends more on healthcare than its peers, yet outcomes for mothers are significantly worse. It shows that economic wealth alone does not ensure equitable health outcomes. Structural inequality, gaps in insurance coverage, and racial disparities and inconsistent access to care all play a significant role in shaping women's health in the United States. For this slide, I'm highlighting the 2023 U.S. maternal mortality data from the National Vital Statistics System. First, maternal mortality is defined by the World Health Organization as the death of a woman during pregnancy or within 42 days after the end of pregnancy from causes related to or aggravated by the pregnancy itself, not accidental causes. The maternal mortality rate is measured as the number of maternal deaths by 100,000 live births. In 2023, there were significant racial disparities in maternal mortality. The rate for Black women was 50.3 per death per 100,000 live births, which was significantly higher than the rates for white women, and Hispanic women at 12.4 and Asian women at 10.7. This means Black women were experiencing maternal deaths as more than 3 times this rate of white women. When looking at age, the risk also increases significantly. Women under 25 had a rate of 12.5. Women ages 25 to 39 had a rate of 18.1. However, for women age 40 and older, the rate jumped dramatically to 59.8, nearly 5 times higher than women under 25. Although some groups saw decreases from 2022 to 2023, these disparities remain significant. Overall, this data reinforces how maternal mortality in the United States is strongly influenced by race and age, highlighting ongoing structural inequalities in healthcare access and outcomes. South Sudan is a low-income country in East Central Africa that has faced major challenges since becoming independent in 2011. Because of ongoing conflict and economic instability, the country has one of the most fragile healthcare systems in the world. Many areas, especially rural communities, don't have nearby hospitals or clinics, so people often have to travel long distances just to receive basic care. There's also a serious shortage of trained doctors, nurses, and midwives, and the government spends very little on healthcare. As a result, a lot of medical services rely heavily on international aid and organizations. These systemic issues have a major impact on women's health. Poverty, conflict, and limited access to care make pregnancy especially dangerous. Many women give birth at home without a skilled birth attendant, and emergency services are not available in large parts of the country. One of the clearest examples of health inequality in South Sudan is the maternal mortality rate. While there has been improvement over time, the numbers are still extremely high. According to the World Bank, the maternal mortality ratio decreased from 3,845 in 2000 to 692 in 2023. Even though that's progress, 992 deaths per 100,000 live births is still one of the highest rates in the world. To put that into perspective, that means hundreds of women are dying from pregnancy-related complications that are often preventable in countries with stronger healthcare systems. This reflects deeper issues like limited access to hospitals, shortages of trained medical professionals, lack of emergency care, and widespread poverty. So while the statistics show improvement, they also highlight how much work still needs to be done to protect women's lives. On this slide, I created a Venn diagram to show the cultural similarities and differences between women's health in the United States and South Sudan. Starting with the United States, we see that it's a high-income country with advanced medical technology, and most births happen in hospitals with skilled providers. However, access to healthcare is often tied to insurance and income, and maternal mortality is heavily influenced by racial and economic disparities. So even though the infrastructure is strong, inequality still creates serious health risks for women. On the other side, South Sudan is a low-income country with a very fragile healthcare system. Many women give birth at home without skilled attendants, and access to care is limited by poverty, distance, and ongoing conflict. The challenges here are more about the lack of infrastructure and basic resources. In the middle, we see the similarities. In both countries, motherhood is culturally valued, and women are often expected to prioritize caregiving over their own health. Poverty plays a major role in limiting access to care in both places, and maternal mortality remains a major public health concern. So even though these countries are economically very different, cultural expectations and inequality impact women's health in both contexts, just in different ways. For this section, I wanted to shift from just describing the problem to talking about the ethical considerations behind it. Maternal health isn't just a medical issue, it's a human rights issue. The fact that where a woman lives, how much money she makes, and her racial and social background can determine whether she survives childbirth raises serious ethical concerns. Access to safe pregnancy and childbirth should not be a privilege, it should be a basic right. Globally, there is a massive inequality in maternal health outcomes. An estimated 90% of maternal deaths occur in low and middle income countries. This shows that poverty, weak health systems, and lack of infrastructure are not just unfortunate circumstances, they are structural inequalities that cost women their lives. Even in high-income countries like the United States, ethical concerns still exist. Despite having advanced technology and high healthcare spending, maternal mortality remains higher than in other wealthy nations. This focus asks us, if resources exist, why are outcomes still unequal? Issues like racial disparities, insurance gaps, and inequality show that access is not distributed fairly. At the community level, there are important actions that can make a difference. Health education plays a major role in improving maternal outcomes. When women are informed about prenatal care, warning signs during pregnancy, and mental health resources, they are better able to advocate for themselves. Community advocacy is also critical. Grassroots organizations, local leaders, and healthcare workers often push for policy changes, expand awareness, and reduce stigma surrounding maternal mental health and postpartum depression. So ethically, this issue challenges not only governments but also communities and individuals to take responsibility for improving outcomes. Taking a look at government responses, we can see major differences between the United States and South Sudan. In the United States, there are structural programs designed to support low-income women and families. Programs like Medicaid and SNAP help provide healthcare coverage and assistance. Additionally, in May 2024, the CMS Maternal and Infant Health Initiative launched new quality improvement efforts focused on two major drivers for maternity mortality: maternal mental health and substance use, and hypertensive disorders of pregnancy. This shows that the U.S. government recognizes maternal mortality as a policy issue and is attempting targeted reforms. However, despite these efforts, disparities still persist, especially in low-income and marginalized women. In contrast, South Sudan has extremely limited government capacity. Healthcare infrastructure is weak, funding is low, and many services depend on international aid. The government alone does not have the resources to provide widespread maternal healthcare access, especially in rural areas. Because of this gap, global organizations play a crucial role. Organizations like the World Health Organization, UNICEF, and UN Women, and Doctors Without Borders provide emergency care, medical training, equipment, and maternal health programs. In many low-income countries, these organizations are the primary providers for life-saving maternal services. Overall, this comparison highlights a major ethical reality. Maternal survival often depends on economic status. While high-income countries struggle with inequality within strong systems, low-income countries struggle with absence of strong systemic altogether. Addressing maternal mortality therefore requires action at every level: individual, community, national, and global. As I conclude this presentation, I want to step back and reflect on the bigger picture of what this comparison has shown us about poverty and women's health. The most important finding from this research is that poverty significantly worsens women's health outcomes, regardless of whether a country is high income or low income. Poverty shapes access to healthcare, nutrition, education, and social support. It affects whether a woman can attend prenatal appointments, afford medications, receive mental health support, or access emergency care. In both the United States and South Sudan, economic instability directly increases health risks for women, especially during pregnancy and childbirth. Another key finding is that women face unique biological, social, and economic vulnerabilities that make poverty particularly dangerous for them. Biologically, women experience pregnancy and childbirth, events that require consistent, high-quality medical care. What that care is delayed or unavailable, the consequences can be life-threatening. Socially, women are often expected to prioritize caregiving roles. In both countries, cultural norms frequently place women in positions where they care for children, family members, or extended relatives. This can lead women to put their own health last, delaying treatment or ignoring symptoms. These gender expectations may look different in the United States compared to South Sudan, but the underlying pattern is similar. Women's health is often secondary to family responsibilities. Economically, women are more likely to experience poverty due to wage inequality gaps in employment, unpaid caregiving labor, and limited access to financial resources. These economic disadvantages compound health risks, creating a cycle where poverty leads to poor health, and even poor health makes economic stability even harder to achieve. Although the impact of poverty varies by country, it follows similar structural patterns. In South Sudan, poverty intersects with the fragile healthcare system, shortages of trained professionals, limited infrastructure, and geographic barriers. Many women must travel long distances to access care, and some give birth without skilled attendants. In this setting, the risks are often linked to lack of basic medical resources. In contrast, the United States has advanced hospitals, cutting-edge medical technology, and high healthcare spending. Yet, maternal mortality remains higher than in other income countries. This reveals a different kind of problem. Not absence of resources, but unequality distribution of them. Structural inequality, racial disparities, and insurance gaps means that not all women benefit equally from the system. So while the form of inequality looks different, the outcome preventable maternal deaths remains deeply concerning. When comparing the two countries, we see a powerful insight. The United States and South Sudan differ greatly in wealth and infrastructure, but they share gender-based disparities. In both places, women's health outcomes are shaped by social roles, economic limitations, and systemic barriers. This comparison also highlights that structural inequality is one of the strongest drivers of maternal health disparities. In South Sudan, inequality appears through limited natural resources and heavy reliance on humanitarian aid. In the United States, inequality appears through systemic racial and socioeconomic gaps within an otherwise strong healthcare system. These are different contexts, but both demonstrate that economic and social similarities directly affect survival rates for women. From an ethical perspective, this raises important questions. If maternal deaths are largely preventable with proper care, then disparities in outcomes reflect failures in access, policy, and distribution of resources. Maternal health should not depend on geographic, income, or social status. Safe pregnancy and childbirth should be universal prospects, not privileges. So what are the broader conclusions? First, addressing women's health requires addressing poverty itself. Medical interventions alone are not enough. Policies must focus on expanding healthcare access, strengthening infrastructure, and supporting economic stability for women and investing in education. Second, solutions must be culturally informed and systemic. In South Sudan, this may mean investing in rural clinics, training midwives, and strengthening transportation systems to reach healthcare facilities. In the United States, it may involve addressing racial bias in healthcare, expanding Medicaid coverage, and improving maternal mental health support. Third, improving women's health has a ripple effect far beyond individual outcomes. When women are healthy, families are stronger, children are more likely to thrive, economic productivity increases, and communities become more stable. Women's health is directly connected to long-term national development. Ultimately, this research demonstrates that maternal mortality and women's health disparities are not inevitable. They are shaped by policy decisions, economic systems, and cultural norms. And because they are shaped by systems, they can also be changed by systems. In conclusion, poverty and inequality remain powerful determinants of women's health in both high-income and low-income countries, such as the United States and South Sudan. By investing in women's health, we are investing in stronger, healthier, and more equitable societies.